You presented data from the CALGB study, and in this study first-line bevacizumab plus chemotherapy has been compared to cetuximab plus chemo in patients with metastatic colorectal cancer. In this trial, you studied the effects of 4 common first-line regimens available for the treatment of metastatic colorectal cancer. Can you explain the importance of this study?
Well, the first question we asked was, is there an optimal first-line treatment? Did it matter what sequence you treated patients in? And if so, what was that sequence? The importance of the study, I believe, at least as we defined the study population, which was patients who were wild-type at KRAS in codons 12 and 13, not in the new expanded RAS category. In those patients, it really didn't matter which treatment you started with, FOLFOX or FOLFIRI, with bevacizumab or with cetuximab. The patients all did very well by historical comparators. The median survival was about 29 months in all patients. So I think the significance is that, in fact, you can make decisions based on what's right for the patient. Do they care about acne? Do they not care? Do they have heart disease? Do they have a neuropathy? All of these factors can be factored in, and you're not sacrificing efficacy by making one decision or another.
Could you tell something about the study design and how many patients received the different therapies?
So the study design was a randomization between the cetuximab and bevacizumab, and it was a physician's choice whether patients received FOLFOX or FOLFIRI. In the U.S. and Canada, that wound up being about 3/4 of patients got FOLFOX, that being the bias of practitioners. So essentially, it was a total of 1,137 patients. About 830 of them got FOLFOX, and about 300 got FOLFIRI, and then randomized between cetuximab and bevacizumab between those two groups. And the results basically showed that, in fact, the progression-free survival was about the same across all the cohorts in the mid 10-month range. And overall survival was a little bit different from one cohort to the next, but in sum, the patients who got cetuximab with either chemotherapy had a median overall survival of 29.9 months, and those who got chemotherapy, whichever it was, with bevacizumab had a median survival of 29.0 months. Not a meaningful difference. Now again, this is not in the expanded RAS or all RAS population. It's likely that if you apply that same metric as was done in other studies, that there would be a slightly better survival in the cetuximab group treated who had all RAS wild type. But we don't think it could reach the statistical significance of the other studies, because in our study, at least, the bevacizumab patients did very well compared to FIRE3, which is the other timely study, where the patients did not do as well on bevacizumab as they did in our study.
How can these results influence the clinical practice?
I'm not sure how much influence it'll have on clinical practice. In some parts of the world where cetuximab is popular, it'll still remain popular. In the U.S., where FOLFOX bevacizumab is popular, it will, even though that turns out to have been the arm with the worst performance of any of the 4 arms, they were all close enough that my bet is that won't change the practice either. I think, again, if it makes people stop and think what's right for this patient, shouldn't be reflexively one or the other, that would be good. And the knowledge that, in fact, you're not compromising your care if you make that decision.
Here in Barcelona, you presented additional data comparing to your presentation at the ASCO meeting. Could you highlight these?
Right. So again, there's been a lot of concern about why the data is coming out so slowly from 80405. It was just released at the end of January, and we're still trying to make sure the data is accurate. It's not an industry-sponsored study. It's sponsored by the cooperative group, so the auditing and it's all on me and the people who are working hard over time. So while I was eating tapas last night here in Barcelona, my lead statistician was back in North Carolina running the data. And so we will report on the response rate, which is of great interest to people, which isn't, I don't think, as important as overall survival. But the response rates are about what one would expect. In the FOLFIRI patients, it's 62% response rate with cetuximab and 61% with bevacizumab. And in the FOLFOX group, it's a little bit higher for the cetuximab, in the 60s and in the high 50s for the bevacizumab. Again, people have been pushing for that result. That's the result, which is about where you'd expect it to be. Other data that we'll talk about a bit is one of the important questions is, do we need to do central RAS testing? And at least with codons 12 and 13, where we did central RAS testing but allowed local testing to put patients on study, we found a 97% concordance between the local and central review, which tells us that at least in many of these cases we don't need central review to make decisions about treating patients. We also have tried to get detailed about the percentage of patients who got subsequent therapies in 80405, and it's 88%, but we're still really, I'll present that, but that data is still soft in terms of knowing exactly how those treatments were distributed. And the other data I'll present is progression, that we'll talk about is progression-free survival, which again really doesn't substantially change the nature of the study. At ESMO, coming up at the end of September, we hope to present a deep analysis of two subsets of patients, patients who are rendered disease-free and are long-term survivors, to try to analyze them, how they got there, and what their characteristics are. We'll also look at the subset of patients who failed prior adjuvant therapy, and we'll have the all-RAS data at ESMO, we hope. Okay?